Okay, hello everybody. Here we are for December's Journal Club. So just a reminder, we do post this on YouTube. I suppose all of you that are here, you probably don't need to watch it on YouTube, but you could share it with people where if you're not able to attend live, we still have it available. So check out the ISU OTA YouTube page for all of our journal clubs. We'll be back the first, I think we're going to try for January 10th. So it won't be that first week, obviously, with New Year's, but we'll be back in January for another journal club topic. Currently, I think we have a outpatient hand clinic that is going to do a topic, so that'd be fantastic. But today we have Joanne Trammel here, program director for the OTA program, but also a mental health lover and advocate. So she's doing fantastic things for the state of Idaho and just for the OT profession in general.
This whole journey has started, Anna, you cracked me up, has started out with our program trying to place students in a mental health rotation for fieldwork. It's been difficult to find places where we can send our students that have actual occupational therapists and not have them tag along with a rec therapist or a social worker or a parole officer, because we've got some great placements that are certainly mental health settings, but a lot of them do not have OT. And the one that's been a thorn in my side is the State Hospital South. Used to have OTs in the day, and for whatever reason they are gone, and it's run by rec therapists, and they do a decent job with providing rec therapy. Well, they do a fantastic job of providing rec therapy, but rec therapy doesn't cover occupations like occupational therapy would. And I just keep hearing our students coming back going, my gosh, nobody is addressing the barriers that these people have with their self-care or their ability to do IADLs that will keep them out of the mental health institutions. So I have just been really wrangling with that whole process. And anyway, it just came to a place where I started talking to some legislators I know and found out that Idaho is really, at the legislative level, is looking at expanding service providers for mental health, not only for COVID, but just by the fact that Idaho is known for having not great mental health services. So that propelled us to talking about it in a mental health group through IOTA, and we were able to get to the table with Optum, which is the service or the insurance provider for mental health services outpatient only. I didn't realize that in Idaho. And OT is not, we're not able to bill for psychosocial services through Optum. We are only recognized on the physical disability side through Medicaid. Optum is the Medicaid biller for Idaho. So we can bill any of our services for the physical disability side, but when it comes to the mental health side, behavioral health, our codes are not recognized in that part. So Megan, help me. And
yeah. Oh, sorry. Yes, Angela, you're right. Angela Zog and Lisa Hall.
Yeah, Angela Zog was able to get us connected with Optum and have a sit down. And out of that, they're interested in hearing from us and learning more about what OT services are available, or how we could, why it would make sense for them to expand their billing for OT through Optum on the behavioral health side. And when I asked how we could get a seat at the table, they said, well, we want a policy statement and we want it in 10 days. Basically over Thanksgiving break. So we were able to do that. And the part that really helped, and this is where this journal article came from, is the state of Indiana was able to do what we're trying to do. And so many states are trying to become qualified mental health practitioners. which we are designated as certified psychiatric rehabilitation providers. So OTs can be a CPRP in Idaho. However, it's a whole different certification process, and they don't just take our degree. You have to demonstrate that you have a certain amount of hours of experience and all that kind of stuff, which qualified mental health providers do as well. And then you're not acting as an OT, you're acting as a qualified mental health provider that happens to be an OT. And the billing is billed out through Medicaid as a qualified mental health, or in Idaho, a certified psychiatric rehab provider. So the billing is probably way less than what an OT would be able to bill anyway. But in my mind, it's like, why do we need to go get a different certification when we have the ability through our degree to provide the services that these other certification deals say that, give us the status when we already have it. So we used the Indiana, well, so backing up, Indiana was able to get their Medicaid billing to open up to allow Idaho or Indiana OTs to become independent billers for their, I forget what it's called, Medicaid rehabilitation option. MRO is what it is in Indiana. So I was able to use that state's example in our policy statement to Optum to bolster our case, along with adding in AOTA has wonderful position statements and information about the OT and how we're the distinct value of OT for mental health. And so we uploaded that.
We'll look at that in a second.
Yeah, we're going to show you guys one of the AOTA PowerPoints that they have, because as Megan says, why reinvent the wheel when it's already there? But I sent an email to let me find it. I had it pulled up. Yes. Okay. That's not, oh, because it went to a different one. So it's not him. So there were 3 people with Optum that we spoke to, and I sent an email to the one. So after that meeting, Megan, I don't know if you got it, but not Matt, but the other guy that I sent the email to. Dennis Bauman searched me on LinkedIn and sent me a request to link up on LinkedIn. So I thought, well, that's a friendly thing. So I sent an email to him today just saying, hey, I've never done this sort of thing with a policy statement and all. Can you just give me an idea on when we might receive some feedback? Because I didn't even get a response to the email. And, what is the timing on this sort of thing? And so he did send me back an email, which, did you see it? Because it looked like he put it on the chain from the original email policy.
When did he send it?
It was this afternoon at 3:45.
I wasn't on that then.
I'm seeing it now. He just sent it to me. But anyway, it's oh, actually I take that back. He must have sent it over to Matt because it came from Matt, and it just says, thanks for sending this information our way. It's great to get a high level view of how OTs have been integrated into mental health networks in other states. And this is where I think they have misinformation, but given that Idaho Administrative Code does not currently allow OTs to provide mental health services, parentheses, unless they are supervised by a psychiatrist, psychologist, clinic level social worker, parentheses, we will need to take this information back to our team and see how OTs could fit into Idaho's mental health treatment landscape. With Idaho having a workforce shortage of mental health treatment providers, we are interested in exploring options to help improve access to quality services for our members and the Idaho community. If you have any questions, please be sure to circle back.
And can I jump in? So isn't Idaho like one of the last ranked states for mental health services / maybe a pretty high ranking in number of suicide deaths? You know,
It
so-
absolutely, yeah, without question. And we provided them that information. So
right.
Joanne, I'm wondering if maybe their language, or we need just to respond. I'm wondering if there's confusion around supervisory versus needing a referral.
Right.
Because I know there's an issue with, we understand that we can't diagnose.
Right.
We would need another approved mental health provider. But so that's what I would just respond with.
Mama, chocolate
We
milk.
recognize
Mommy,
my 3-year-old. We know that we need to have the referral, and those different providers that are listed are able to they're able to diagnose from the DSM-5.
Right.
So that's what I would just recommend responding with, just to clarify that.
Sure. But he didn't answer my question because I was looking for, can you give us a time frame on when we might
Yes,
know
did not.
something? Yeah.
And I mean, so again, I'm tying back to the article because it's neat, I guess, that he's recognizing that, because the article that kind of summarizes Indiana's process, but that receiving recognition, a case for occupational therapy practitioners as mental and behavioral health providers, right in the beginning of the article, it really snagged me because it says like this importance. And part of it was that let's see, there was an analysis that found that an additional 10,000 mental health care providers will be needed by 2025, which really isn't that far away anymore, to meet the expected growth in demand of treatment with people with mental illness, substance use disorder, or both. So despite being the largest payer of mental health services in the US, the Medicaid program has extremely low numbers of mental health providers, where I guess it's, I mean, that's pretty empowering right there of, we are a field that is right here, willing and able and capable. And then we have someone that's on the billing or the insurance side of it that is at least acknowledging that there is a huge deficit. So, I mean, how cool is that for our field that we can hopefully push? I mean,
Right.
That's what these guys
So,
are doing.
Yeah, and I just hope that they will continue to reach out and help us to continue to clarify with them that, like what you're saying, Megan, is that we don't need supervision. We just need somebody to refer, and then we will do the treatment and supervise the assistants that we will use as treatment extenders. And that's really where the cost savings is going to come, because I think the payment is part of the issue. And I would venture to guess that an occupational therapy assistant pay is going to be comparable to a social worker or, their treatment extenders out there in the field as well.
Counseling.
So, counseling, yeah.
Right.
So the cost is not going to be that much different to what they're already paying. And I would say that the service that they're going to get, they keep talking about quality and all this. Well, heck, I'd say that we provide quality mental health services, and it's just going to help students in school get more excited about mental health. And the more OTs we get out in the field practicing, then we'll have even better fieldwork settings that will have students coming out having the 320 hours for an assistant and however many it equals for 12 weeks of an OT student in a specialized mental health fieldwork setting, rather than going to Rexburg juvenile parole and falling around a social worker doing home visits, which it's a fantastic rotation for our students, because they see that most of these kids are in trouble because they don't have occupations to keep them out of trouble.
So
Go ahead.
the perspective I got listening to the email, I'm wondering if they think that we're trying to do the same thing that social workers and counselors are doing, rather than being a complement to them. And that might be where they're getting well, you would need to be certified in this realm as well.
And I wonder, well, so in the email that I sent with the policy statement, we are hopeful that after reading this, Optum will be encouraged to consider occupational therapy practitioners as service providers for Optum beneficiaries. Service providers, I'm not saying, And maybe service provider is a term that they consider a psychiatrist or a social worker. So I might have used the wrong terminology for that. I'm
I
thinking,
don't think there's anything wrong with that, but they might be taking it the wrong way.
right. And so that's where the clarifying, if we can continue to have meetings or email exchanges where we continue to clarify what both sides are looking at, hopefully we can get to where it is that we want to be.
And can I talk about the fieldwork and what
Yeah.
we've seen with our students so
Yeah.
far? I mean, so this is where I think the discussion, the article does go into, and if we get to the PowerPoint from AOTA, it obviously elaborates a lot further on what could our scope of practice be in adjunct to the services that are already provided in mental health settings. Because that's something like Joanne said, you know, in the OTA program here, we've sent students to State Hospital South or other inpatient psych centers or units with recreational therapy, which has been amazing. And let me talk about the other topics and then, or the other settings, and then we'll kind of summarize. But, you know, probation and parole, we've sent them to the Youth Development Center here in Pocatello. We've sent them to, like different counseling centers that have programming available for people with a wide variety of diagnoses, or maybe it's specific to substance use and abuse. Maybe it's specific to like job vocational rehab type settings, you know, where we can all think about other, you know, like clubhouse models for those with mental health illnesses that are receiving counseling or having groups and things like that. Most of which, you know, all of those settings that I just listed, except for the Utah State Hospital in Provo, Utah, that has OT services. All of those other ones that I just talked about are led by some other clinician, where we challenge our students to go out to those settings and look at it. And we work with them kind of behind the scenes on what is the OT scope of practice, or what would our lens be in this setting that's a little bit different, and how can they advocate that to the social workers, to the rec therapists. Do we want to maybe have a discussion about like what is OT scope of practice? And maybe I'll set the prelude here of the article talks about, let's see, so we can obviously ADLs, then they specified medication adherence, peer interactions, hygiene and grooming, time management. Other things are improving education and work performance and outcomes for adults with mental illness. Another systematic review talked about that OT, there's strong evidence for OT as a discipline being effective in managing aggression, managing rejection, and then preventing bullying. So it's like we can think about, and we've talked to our students so many times about, you know, deep breathing and relaxation and coping strategies, but I know our students have seen other disciplines doing similar things. So what can we as OT practitioners go out and advocate, whether it's to other disciplines, whether it's to physicians, whether it's to Optum and trying to get, you know, billing accepted from OT providers? Please contribute.
I was going to say, because I am like constantly doing all sorts of different presentations, and just did one recently on OT scope and functional cognition. And it's advocating for what sets us apart. We are the one profession that is going to take all those skills and do it within the context of occupation.
Right.
And that's huge. And that's the issue, because you hear about that. You're like, yes. And should other professions be incorporating some of those things? Absolutely, they should, because if that client is hearing it multiple times and it's integrated in different ways. But that is the number one way we need to advocate. We are the only profession that's going to do it in the actual context of the activity itself.
Yeah.
And that's on us too, because if we are not truly practicing occupation-based, this is why other professions are snapping this up. So it's on us as well to make sure that we're practicing in an occupation-based manner. And that we are able to demonstrate the benefits of that from a mental and behavioral health perspective.
Yeah. So, and I just want to touch back on, so the lead into the actual policy statement, reading my words, I did say, this policy statement will describe the distinct value of OT intervention with people with mental and behavioral health needs, It also describes the knowledge and skills occupational therapy practitioners bring to meet client needs. Occupational therapy practitioners are collaborative by nature, and we seek to work with and share our unique view on behavioral health dysfunction with other core mental health professionals. So I really stress that we want to work beside, not on top of or over any other professional. And then ultimately, it is our aim that Optum Idaho will understand the value of including occupational therapy practitioners as part of the treatment team for Idahoans who would benefit from occupational therapy focused behavioral health interventions. And then by including us in behavioral health treatment plans. So I'm not saying that we're going to own the treatment plans, but participate with and be part of treatment plans that will improve quality of life. So, and then there's all kinds of stuff about occupation-based, but I don't know. You want to beat your head sometimes about what people hear with what you intend to say. That's okay. So the other thing I wanted to point out is that we in Idaho, like I said, we do not have to worry about trying to go for the qualified mental health practitioner that some states are going for, because Idaho already has the certified psychiatric rehab practitioner. But that is a certification that right now, if you want to bill in Optum Idaho, you have to have that certification status currently. And we as OTs we meet the criteria pretty much, but I think there's just a little bit more actual work experience, and I don't know if we have enough. If you didn't do a specific psych field work, there's a certain amount of hours you have to have special, particular with mental health. But my point is, why do we have to have that special certification? Social workers don't, psychiatrists don't. Why do we? Because we get our own psych stuff in our schooling.
And I guess, so the article goes into talking about OTs provide services and interventions that support mental health and recovery-oriented approaches as part of their practice. Their training includes participation in at least one clinical fieldwork experience that focuses on psychosocial issues. And I'm sure that not that that varies from program to program, but the depth of that experience. So I'm trying to get one of our graduates on that. She pursued mental health and did a full 8-week rotation, where there's no doubt about it that graduate has competency. I did one of my level 2s, a 12-week rotation in a mental health setting, where hopefully I came out with competency. Though I know with the OTA program, we designate our level 1, one of our level 1s, as that psychosocial fieldwork, which meets our accreditation standard. There's Lucy now. So meets that accreditation standard that I think this article is talking about, that we have a psychosocial rotation. There's probably some debate on, is that the same for everybody? Because I know some of our second years that are on here now, they have they had a level 1, which is a 1-week rotation, potentially without the OT, though we have supplemented that. So I still feel like they get a very strong OT perspective. But if they don't do the level 2, would that still fit that, I guess, that guideline? But then the other thing too is, we think about the full curriculum in itself. Like, we have a whole class designated to psychosocial deficits, not to mention prerequisites for the program. I'm sure the MOT and maybe Mandy and Heather, you guys can speak to that. But our programming, like abnormal psychology, there are other things where it talks about
general psychology, then abnormal psychology. We don't do a lifespan psychology, but we definitely talk about lifespan development and how that affects occupation, which is kind of the same thing throughout the program. And then the psych specific class in the program is what our students get.
And Heather and Mandy, do you guys, I imagine you guys have your psych course, like a full course designated to that as well, in conjunction to your psychosocial rotations. Yes.
Yeah, my psychosocial rotation was just the level 1, so it was shorter. And because of COVID, it was just online. Heather, was that the way it was with you?
No, mine was also level 1, so just the 2 weeks over at the VA in their MICM program. But yeah, we have your prereqs are the same thing that you had said, Joanne, abnormal psych, psychology, and then we have our full semester of psychosocial mental health.
Yeah.
So
Yeah. So Lucy, we're talking about OT practitioners having enough to make them competent to be a psychosocial practitioner out in real life. Do you have, now that you're practicing in the behavioral health unit, do you feel like the program gave you what you needed to be able to walk into that job fairly competent?
Without needing to pursue other certifications to be a quote mental health provider.
Do you feel like the program, is that what you mean? Sorry, I kind of just hopped in.
Coming out of school, our
Coming
OT
out of
program.
school,
Can you
yes
just-
and no. I feel like that's one of those settings where it's hard to teach, and like you have to see a lot of those illnesses and those behaviors. I don't know. Don't ask me. I don't know. I feel like the hands-on portion really helped. And it's one of those fields where you do need to see
Yeah.
either in a field work or in pursuing other ways of being able to have exposure to that, just because there's so many different forms of mental illnesses and how it impacts people, that I think for me, if I hadn't had the field work options that I had, just with the classes that we had and stepping into Utah State or BHC, I would have been shocked, a little scared, but
Yeah. And
at
so
the
what
same
we're,
time, with my personality, I enjoyed it. So I don't know if I'm the right person to ask
well, now
this
what,
question.
and then I guess what we're saying, Lucy, is that because you did have that rotation down at Utah State Hospital, specialized psych rotation, and we're saying that if we can get OT practitioners out there more in mental health, that there would be better or more available specialized psych settings for the full 8 weeks or 12 weeks, or there would be more OTs ready to go and have what they need to practice.
Yes,
mental health.
okay, I understand the question better now. Thank you. Yes, if there were more opportunities such as those, then I would definitely think that entry level would be attainable for, incoming newly graduates that were interested in that. I think it'd be possible and incredibly beneficial.
And especially if a level 1 rotation, where I think that is kind of a common thing, where unless a student has a passion about mental health and they pursue that as their level 2, if they had a level 1 for the MOT program being a 2-week rotation, for the OTA program being a 1-week rotation, if there were more sites out there that were guided by an OT practitioner, because there were more people with that passion getting out there and expanding our outreach and our, I guess, connection to those populations, then I feel like, and maybe some of the current second year OTA students that are here, or even Mandy as a current MOT student, it could broaden or maybe enhance that 1 week or 2 week shortened experience, but give you that greater application into OT because you're with an OT versus trying to extrapolate that with your faculty behind the scenes while you're going with, a caseworker or a counselor or whoever.
Like following rec therapy, but not seeing the OT perspective, definitely. Just getting the clinical value of like specifically what we're doing and what we bring to. I agree.
Because Lucy, did you do your level 1 at State Hospital South, or where were you? Do you remember?
No, my level 1s were Handex and life care. And then my
Oh,
level
that's right.
2s
Okay.
were Utah State
yeah.
and Community Hospital.
Yeah, so you have
So-
life care focusing on dementia, but yeah, I know Amber went to State Hospital.
Yes. Yeah, so I went to State Hospital South for my level 1B. And it was honestly such a great experience, but I just wish we did have the OT perspective. It was really awesome, like seeing where the rec therapy fit in and what they could do, but it would have been really nice to put into practice what we'd been learning as OTAs.
Yeah.
But I mean, I do think the students that especially have gone to State Hospital South have come back and have said, holy smokes, you know, ADLs in general, you know, like we're not getting as clear. I mean, not in any way, you know, talking down rec therapy because they have a huge value.
Absolutely.
But when we're missing the whole self-care integration back into the community beyond a leisure perspective, I mean, that's potentially a huge piece of the puzzle that's missing, that's leading to the revolving door or leading to further issues, which I think if we can, you know, communicate that value of, you know, just like Megan had said, we are tying it directly to the occupation, which would be like, how can you leave this structured facility and integrate back into your normal routine and occupations in a more productive way, using X, Y, and Z, you know, skills and coping strategies that can come from all disciplines, perhaps.
Yes. So do we want to show the?
Yeah, so I guess let's just take a look at what, I mean, so I think a big part of this certainly is any of us becoming extensions of the work that Joanne and IOTA and that committee are really working for, of how can we promote our discipline, our profession. So I think the biggest thing that, you know, in outreach and attempts to touch more practitioners that could potentially be advocates out in the community, again, whether it's to insurance providers, family members, physicians, other disciplines, et cetera. Let's take a look at what AOTA already has about the greatness of our profession. So this is, I mean, if you're a member of AOTA, you have access to this PowerPoint, amongst other things, position papers, a whole bunch of other references, obviously the article that we talked about earlier. So I think, let's see. So obviously we have all of that. I think one thing, I mean, like thinking back to OT's roots being in mental health, I think that's one thing that maybe can kind of get lost.
Yeah.
That this is where our profession started,
Yeah.
and we had it in mental health.
And I did include that in the position statement, helping them understand that we started and that the whole idea of that an occupied mind with whether it's a craft or growing things in a garden is going to take their mind off of their what they're stressing over, or their war injuries, or their mental health issues at the time. Yeah. So doing an occupation is, we know, and it's evidence now that it reduces mental health.
And that's basically what we all know what OT is, but this kind of can help us refine our elevator speech of what is occupational therapy, and then how is it a critical piece to mental health care. So then obviously we know, you know, obviously our professional requirements, you know, it's quite an extensive process to become an OT and an OTA. You have to pass your boards exam, you have to pass your fieldwork, so you have to maintain a professional license. So OT in mental health. So we should be a component of that interdisciplinary care that complements mental health treatment. So again, you know, like no territory battle, or, you know, we're trying to replace rec therapy or social work or whoever. It is another complementary process, just like in inpatient rehab, where sure, a PT can do it all, but you know, can they, you know, but an OT can complement, and we can provide a more robust array of services with a broader scope and broader perspective that can really help that patient in a greater way. So we are trained to identify the specific individual and their environmental changes that are necessary to achieve goals. We can look at strengths-based strategies for improving functional capacity across an array of domains based on the consumer priorities. And we can address health and wellness needs, recovery support, and social determinants such as housing, educational, and vocational goals. I mean, I think that's huge. Where that, that's the age-old thing of, I don't need occupational therapy because I already have a job. So why are we not involved when somebody potentially doesn't have a job, or they're not succeeding in their job and they have these mental health barriers that could potentially be the reason behind that? And people, please jump in if you have anything you want to comment on. This is very relaxed. So why OT in interdisciplinary teams? So independent living skills, functional capacity, to mitigate the impact of mental illness, in conjunction to coping skills, and so again, I think a lot of disciplines discuss and talk about coping skills, but tying that to the occupation, maybe even, participating in that occupation with someone, whether that's a job site evaluation or something where you can see how the mental illness and impairments related to that are directly impacting their participation in that occupation, and then hopefully enhance the utilization of those coping skills. And then reduce symptoms of mental illness through engagement in healthy roles and routines. I think this is a whole different topic, but wellness in general, why aren't we doing more preventative work for a variety of conditions, and how can we, reduce symptoms or promote healthy roles, promote healthy routines, whether it's, I guess, preventative or once we're identifying barriers. What do we do? You want to talk?
So actually, Lucy, I want to know what you do. I think you're the only one on here that actually is working in behavioral health right now.
Okay. As far as treatment I provide, okay, so I just want to know, and you guys may already know this, but I didn't really get it until I came to BHC. My experience at Utah State Hospital with there being a long-term unit, it didn't really sink into me that BHC is an acute care. And so those two different settings, which I didn't understand at first. So in one setting with the long-term, you will get more of those life skills, like basic cooking, depending on your cognitive levels. You'll get, once a person's ready for discharge, you'll get those community reentry classes. And those are great, like life skills for being able to maintain as much independence as possible. And I like that. And I was like, oh yeah, we'll do all the things at BHC. And then I got there and they were like, this is acute care. I'm like, what does that mean in mental health? So I had to relearn that. And so a lot of what we do is what Brittany was just saying. There were already programs there that BHC was using when I got there, but I worked with some great OTs. They really trust my competency and they let me put together my own program that I wanted to use, research-based, of course. And so I do well-being classes, stress management. So all of those things that, while in the acuity of the setting, will help them manage their symptoms, which you basically assume they had reached a point where they boiled over and something happened where they are unable to manage their symptoms. And so we keep it to, how can you help yourself right now? Like, how can you manage the stress? How can you recognize your symptoms? And then how can we keep you on a medication plan or help you to continue your counseling classes, even if it's just referring them to a caseworker, like that'll help in that specific setting, help them to get back on track to try and manage their symptoms to prevent that kind of breakdown from occurring again. So that's what it looks like for me as an OTA standpoint.
How do you distinguish what you're doing from what social worker counseling would do?
So sometimes the classes and our topics do overlap. What I'm doing is in the focus of how they can function the best as an individual with considering where they're going to be discharged to, an assisted living or a group home independently with their abusive parents. Taking that whole person, that holistic centered approach towards the individual, that's when I kind of cater what skills I'm going to teach to the person. And so I'm not going to waste time making sure a person is on top of their medication management if they're in a skilled nursing, because a nurse will always bring that to them. However, them being able to recognize that when they're becoming upset and escalated and they don't find some other occupation, that they start to spiral. So trying to pull that in where we're not like, okay, well, here are these coping skills for everybody. I'm trying to look at what a living environment they're going to be discharged to, what their support system looks like, their mental and their cognitive abilities. So I guess we have more leeway or more ability to consider all those options and make it a more personable plan.
Yeah. Somebody's chat.
Mandy says, do I see clients one-to-one or in a group setting? Usually both. So my OTs will do the evals. Everybody gets an eval because of the way the billing there is set up, which Joanne could explain a lot better. So everybody can have OT if they want it. So they can come to my groups if they want it. No one's forced to come. And then there are opportunities for one-on-one treatments where if we have a patient who has been homeless for a while and is lacking in, those basic ADL self-care skills, I will go in and work with them one-on-one, and I'll bill for the one-on-one treatment and set up as a group setting. But I do have opportunities to do both. And sometimes it'll look like, all right, are we showering? Let me see you step into the shower safely. Are they using grab bars? It'll look like that. Or on the adolescent unit, it could be, okay, well, you're threatening to complete suicide when your parents tell you to pick up your room. You don't think that's right. Like, let's talk about, let me educate you on family dynamics and those kind of systems. Like, try to give them another perspective, try to provide education. So that's what's great about OT. It could look like any number of things depending on what the individual needs, but yes, group and one-on-one to answer very long-winded in a very short question.
Yeah. And can I ask, what other disciplines are there at the BHC? And so BHC, Behavioral Health Center in Ermac, so Eastern Idaho Regional Medical Center in Idaho Falls.
Okay, so I attend rounds every morning, and so we've got psychiatrists, we've got nursing, we've got psych techs, we've got case workers, social workers, we've got rec therapy and OT, and then speech and physical therapy will come over as needed. But as far as the full time staff, that'd be everybody.
Awesome.
So that sounds exactly like what it was at the acute Jerry Psych Hospital I was at in Twin. OT was part of the treatment team, and PT and speech came in if med changes affected swallowing or balance and that sort of thing. But otherwise, OT was there for everything and doing a lot the same, trying to help people. My folks came in mostly dementia, but they were aggressive or had difficult behaviors in assisted living or skilled nursing, and they didn't want them in there because they were a threat to staff or other patients. And so I was working to help find the non-pharmacological interventions to help them return to their highest level of independence. And sometimes
and this can be a separate conversation, Joanne, but my brain has tingled during rounds when, we get the 70-year-old patient and they are suddenly so aggressive and upset, or it only happens at night and they start pacing a lot. And I'm just like in the background, like, is this sundowners? Is this dementia? Like, should this person be here? This is not a mental illness. Like, and when someone presents at the ER and they don't know what to do, they just will oftentimes throw people over at BHC. And that's same with people who are currently high or whatever. It almost becomes a catch-all sometimes, which is interesting.
Exactly.
So if anybody has suggestions on like what to offer the treatment team on how to work with that. That'd be great too.
Yeah. I don't have a real good answer for you, but other than it happened, and most of the time it was UTIs, and they didn't know what to do, or they just saw the behaviors. They didn't consider the underlying cause for the behaviors.
What a timely next slide.
Interdisciplinary, yeah. So I found myself doing a lot of education too about people need ways to occupy their time themselves, so that they decrease the behaviors. And I just remember one guy I fixed because he got rude in the dining room in his assisted living, and they didn't like that. And so, because he yelled at other people that were loud. So I got him a pair of earphones that he could listen to his country music, and he was happy as a clam because he didn't have to listen to anybody else, and he could hear what he wanted to hear. And he got discharged and went back and wore his earphones. Oh, it'd be nice if I could read this.
So we help people resume their past roles or master new ones. And so then it highlights that we do that by identifying goals and assessing capacity and identifying barriers. Then obviously the goal setting and skill development, promoting participation, and improving performance.
So the promoting participation with mental health is one that has always been a thorn in my side. A lot of mental health facilities, behavioral health centers, whatever, if somebody doesn't want to go, it's like, okay, we'll come back later and check on you later. And I just, as an OT, I don't like that. There's therapeutic use of self to get people motivated to want to come out and participate. And I feel like that's something that sets us apart too.
Someone who is depressed and hasn't gotten out of bed and showered and brushed their teeth is not going to want to get up and go to a ceramics class or what have you. And so it's counterproductive to let them choose when they're so, like you're not doing your due diligence by not encouraging those options, because the patients will often choose not to come. And I've experienced that recently in the last couple weeks. We've had a lot of really, really sick patients, and they don't come to groups because they're sick and they don't want to learn about, stress management because they really want to check out of life. And so it takes a lot of knowledge, education, working with nursing to try and get them to encourage patients to go, because if you don't make that change, what's going to change? So, but
Yeah.
I see that it's hard, and they're always like, well, they're adults, they can choose for themselves. And I'm like,
Yeah.
okay.
Yeah.
I mean, and yeah, like that's a huge point, because that's part of the pathology, is they're not in a place to make
A good
best
choice.
decisions.
Yeah.
Yeah. And then, I mean, so the little bottom part there, it says use activity analysis. Ooh, all of the graduates or current students just shivered a little bit, but hey, we do use activity analysis all the time. And that's the beauty of it. Like, what if the client, has no idea why ceramics is going to help them with their problems or whatever? I mean, it's the ability to use either, whether it's find that meaningful occupation or utilize that modality of ceramics to open up into another skill or another conversation point, or exploring leisure or whatever it is, but using the activity analysis to break down the skills so that they can be gradually mastered is what it says. But I think also to be able to use something, whatever's in your group or however you've designed that group, to then ease your way and apply that to that individual's needs. I think that is a wonderful skill that OT practitioners absolutely have. That's what we do day in and day out in any setting, but we can apply that certainly in the mental health setting. Okay. Oh, examples. So treatment engagement,
health promotion, improved medication. Yeah, so these are all the things we know that we can do to help people, veterans, transitioning, structural wellness planning, this is the meat and potatoes of what occupational therapy is all about. And we just really need to be so mindful of how we document, even in physical disabilities, that if we can continue to document that we're talking to our people getting ready to discharge with congestive heart failure, and we know they're going to go home and sit in a chair, but if we educate them on wellness and health promotion and start using this lingo to weave it into practice, and physicians start seeing this stuff and recognizing that OT addresses this, that will also help us segue into mental health.
And something that's catching my eye right now is school-based mental health promotion. And I'm sure Lucy can speak to this at much greater detail than me, but we can all imagine, you know, obviously over the last year and a half with COVID and quarantines and isolation and things being limited, you know, social engagement being limited in conjunction just the normal daily stressors that we're all still experiencing. Goodness gracious, our younger populations are probably exponentially increased. Lucy, is that a fair statement?
I would think so. I don't know what the numbers were before, but I recently have read some articles come out saying, like, analyzing the effects of COVID and isolation on teens. And so since they aren't able to do the face-to-face interactions, they're left with social media, which even pre-COVID we knew could be so destructive to mental health, especially teens. And so a lot of them, with only being able to see each other and interact on TikTok or Instagram, they're seeing this, I don't know, it's almost like insidious, because people can pick and choose what they want to portray. And it just gets to teenagers when they're, you know, so open to, oh, this is real life, and this is better, the grass is greener on that side. And it has been really difficult from what the teens are telling me. Usually with every new group I get in, I'm like, what's it like? What's so hard for you? And they're like, social media. And then with isolation on top of that, it's just kind of compounded and made life more difficult for already a really hard stage of life.
And
You
we
know,
think
and
about, oh, go ahead. Who is that? Karen?
sorry, it's Karen. And you know, not only just the teens, Lucy, and I was interviewing for a job and asking about if they're seeing a lot of autism, and they are seeing more children that are having behavioral problems, and they're contributing to the isolation and COVID over the last 2 years. And they're seeing much more behavioral issues because of that too, in the mental health area.
Well,
Yeah,
and
I've seen a lot of that in our outpatient too, are a lot of our kiddos where, you know, we don't have proof that they're coming from not great homes, but we highly suspect it. Behaviors have become greatly increased. They have to be at home more, and these adults that are already lacking the education or the ability to give quality caregiving are stressed out, and now they're more stressed out with these high needs children. And so it just is like a recipe for disaster. But we've seen a lot of behaviors increasing just because everybody's stuck together, and it's just a lot harder because now there's not the escape of school, or there's not the escape of the friend's house, and
yeah.
just hard on everybody.
So this is kind of a good segue into Lisa. Can you talk about the meeting that you were able to be part of?
Yes, I can. So Lucy had a connection with, and now the official name is gonna leave me. So Lucy, if you have that. But it was a group of mental health providers in mostly Eastern Idaho that they meet on a monthly basis, and had a connection with Lucy and wanted to know more about what is OT and what do we do. So so I got a chance to talk with them. It was about a half hour or so. I got to present with them, and it was kind of a conversation too, in a Zoom setting, where they were able to ask, you know, what we do. And there was a big a parent group that was like a volunteer type group, or, you know, they weren't paid on this committee at all. So so representing parents of people with mental problems, and they were really excited about OT. Some of them had had some experiences. Some had like experiences in, say, like infant toddler or, something like that. But they were just really excited to hear what the differences are. And so we're following up with some, more written information for them and how to access OT. So I appreciate Lucy getting the word out there and giving us that opportunity. So it was awesome.
Yeah, and so I just really want to, we're at 7:30, and I just kind of want to capsulize everything. So those of you that are on here that are not working in mental health, but are out there in acute care or in skilled nursing or an outpatient, this is the opportunity. Idaho really is looking to expand available qualified mental health practitioners. We know we're beating the drum, to ourselves that we know we can do this. And so anytime that you have an opportunity to put a bug in a physician's ear or a payer's ear, a parent's ear, that OT is ready to come and walk alongside other mental health providers to offer these services. And that if they can help advocate for us to Optum to include us in their billing services, that would help expand the opportunities in Idaho for people dealing with mental health issues.
Do you have a specific legislator that you're working with, or is that down the road?
Yeah, we're not in the legislative. So when I was talking with Carolyn Merritt, who is the lobbyist for IOTA, about Lisa and I were talking with her about wanting to do something like this. She was saying that usually when people want to change insurance or their practice act or whatever, you either go a legislative route or you go a Medicare, Medicaid route, or Medicaid route, because Medicaid is state funded. So right now we're in the Medicaid route of trying to get them to open their, what do I want to say, ability for us to be providers in their system. If that doesn't work, then we may end up going a legislative route. And that's where we would start hounding state legislators that are on the Behavioral Health Committee to get them to make a law in Idaho that OTs are able to do whatever. At least that's the way I understand it. I could be wrong.
And Indiana went the payers, or they
Yes.
went through Medicaid and
Yes.
were successful.
Yes.
So there is at least a track record in the US of where this has come to fruition.
Yes. So I think I'm going to respond to the email that we got back from Optum and just clarify a little bit more that we're not looking to go on top of social work or psychologists. We want to work alongside and just be another option, and that we understand we would have to have a physician or somebody to refer us and do the diagnosing part, but then we would carry out the interventions.
In conjunction to other disciplines.
Yes, correct.
In an interdisciplinary team model.
Correct. And see, I have no idea how this goes from here and how long it takes or anything like that. They just kept saying that the timing was perfect because Optum is looking to go inpatient. Right now, they only offer outpatient psychiatric billing, and that they're looking to go inpatient, which is where State Hospital South. So that could be really a big deal for us.
Joanne, that brings up a good point, because I was thinking about the outpatient world. There's very few practitioners, especially that work in adults and older adolescents. Like, I'm in a small clinic now and I have, 5 patients, and we kind of are on that border of functional cognition, IADLs, mental health. Like, everybody that has ADHD also has anxiety and depression. So it's
right.
We can't bill for ADHD either, but like, who are we going to send them to if they're not in an acute care or an inpatient? Like, we also need to create these opportunities for OTs to expand.
Yes.
So I think that needs to also be just brought up, that they don't always have somewhere to refer them to.
Yeah, exactly. Exactly. So I do have a group through IOTA for this mental health committee. So if any of you that are on here that weren't already on that group, reach out to me and I'll include you. So we'll just continue to pound the drum and hopefully get something going to where we can be the second state in the country that is able to change the Medicaid billing. I just think that would be awesome for Indiana and Idaho to be the two states that get Medicaid change.
Yeah.
I just put Joanne's email address in the chat so you can reach out to Joanne. Or you have, if you saw the flyer, you have my email too, but
Yeah. So in any ideas, I am definitely not a know-all on this subject. I just had the idea and the energy at the time. Now I might be regretting, but any ideas or experiences you guys have, please feel free to reach out and give me that as well.
and I'm just scanning through the rest. I mean, the PowerPoint has fantastic information where again, you can get this on AOTA, but just wanted to get through the last little bit so you can see it for your leisure.
And truly, sometimes this is all like one opportunity. Somebody happens to run across somebody that is the right person at the right time. You make the comment and the connection is made, and that's how it happens. So that's why I encourage you to just kind of keep your ears to the ground. And if you see somebody that is a physician that might be connected with Optum that could make the connection, or a social worker, anything like that, don't hesitate to advocate for our profession.
Well, here we go. Advocacy. Why OT in mental health? We bring unique skills, capabilities, and perspectives. Spans the boundary between the behavioral and the medical arenas. I mean, and this is where I'm stuck on schools, because it's like I've heard so many new, news stories of high school students, elementary school students, middle school students committing suicide, where it's like school-based OTs or just practitioners in general, they have so much to do just for behaviors and classroom engagement and handwriting and just all of the other school, traditional school-based OT of like, is mental health even being provided? They're probably
it's all full-time jobs for several people to just go to the local schools, different class, different school, and promote mental health. It's needed. It would be preventative and beneficial, and it would, I don't know, like it could be a whole job. We need that.
This is our future.
How do I make it happen?
Yeah. This is our future generations coming up in this challenging time, but then in conjunction, it's kind of a pivotal point for our profession on how can we continue to expand, and maybe we'll get to a point of, people don't mistake us for PT or something. They truly understand all of the different realms of OT, because maybe we made a huge difference in their school environment, looking at the whole person. I mean, just.
And Mandy, take it back to your classmates. We need OTs to supervise the OTAs that I'm getting excited to go out and practice mental health. So we need OT partners to get out there and start really just making Idaho great and bring us up from the bottom of the nation in mental health wellness.
Can Brittany and Joanne, I came in kind of late, so I probably already missed something that you had mentioned. Why is Indiana, and now Joanne, you such a pivotal part of trying to get Idaho involved in the recognition of our profession in mental health? Are other states even coming on board too?
So many, there's like 14 states that have become recognized as qualified mental health practitioners. And this is where it all started, is the IOTA wanted to pursue or look at the viability of us becoming mental health practitioners, qualified mental health practitioners. So in looking at that, I came across this Indiana deal, and it just, it's like, why do that when we are already qualified by our degree? So
right, it seems just kind of sad that we have to go back to where we started from to promote our occupation.
yes,
So yeah,
exactly.
sorry. Yeah. Thank you.
Sure. So happy to see so many on today. And do we know what we're doing next month?
Next month, watch for the invites for confirmation, but should be January 10th, and it is a outpatient clinic talking about some outpatient related topic. So hand therapy, orthopedics, we haven't dialed in the exact topic, but it's Nate Long he's a hand therapist from Idaho Falls Hand Therapy. They're fantastic up there. So to be continued, watch look for an event on Facebook. Please email me. I'm gonna put Lucy's new email address that I have on my listserv. If any of you others.
I got it on my work email, but I wasn't on I didn't have my laptop with me, and
Perfect. So
yeah,
that work email.
I'm a mess, I'm sorry.
You're totally
We're
fine.
trying to become savvy and have a listserv that we can send out that we don't have to rely on social media because not everybody has it.
Yeah, I'm not on it anymore, so emails are great.
So again, please reach out to me if you want to be on that. My email is Pete BRI2 at isu.edu. I'll write it in the chat. So if you want to be included on future emails, please reach out to me and I will get your name on there. It's better than spelling I guess you all have it here. Brittany Peterson at isu.edu. You can see it's BRITTANY. But all right, well, so thank you all. And again, share the words, share our invites, share the recording on our YouTube page. Let's gather up some excitement to get more riveting conversations like this. So I appreciate all of you guys.
Thank you.
Thank you.
Thank you.